Maya is going to hit the record button, and maybe Maya could use mute folks. Thank you. Let's see if that worked. Oh, actually, I'm going to mute somebody. Let me mute.
California.
Yep. Let's mute. All right. Can you guys hear me now? I think we're good. I think we got all the mute stuff taken care of background. So I'm Beth Holloman from OHA, and I am super excited to see all 33 of you in this meeting today. If you remember, those of you who were here last month, we had planned this really rich conversation around sort of talking about stabilization services and how do you guys know who might be a good fit for stabilization services? When do you enroll youth into stabilization services? When might you just refer them back to their current provider? And so we had a nice discussion around all of that. However, I had a ton of technical difficulty, if you guys don't remember, if you weren't here. So I missed out on most of the conversation, and I apologize for that. My partners who are here and stepped in, thank you for stepping in and helping to keep the conversation going, were able to inform me about your conversation and sort of some of the themes that came up. However, I did hear from a few people that, you know, there's still more conversation that might need to happen. And so I just wanted to make sure for today I didn't schedule a topic specifically other than sort of continuing where we left off last time and seeing how people are feeling about, you know, sort of the MRSS model and some of the discussions you all had and any sort of lingering questions or thoughts you had based off of the discussion last time. Before we jump into that, though, I do want to make a couple announcements and some updates. And so, Brian, I wanted to start with talking a little bit about MRSS trainings. So I know you all have the Training Academy, and I know that you guys have sent, you know, I think almost 200 staff have gone through the Training Academy. In addition to the Training Academy, the Child and Family Behavioral Health Unit also wanted to provide some child-specific trainings to those of you working with or who might be specifically working with youth and families, or, you know, your mobile crisis teams if you have one team that goes out regardless of the age. But we wanted to add a couple more training opportunities for you guys. They'll be open to all child and family providers that provide services for OHA, but we're going to prioritize the topics are going to be prioritized around this crisis response, community-based response, and we will prioritize your staff enrolling in those trainings. Brian, do you want to take a minute? You worked, he had to send, you know, we had RFPs out and all of that good stuff. And so Brian has been working diligently to get some of this, these trainings up and running, but any updates, plans, template, timelines for when those might be available, anything that might be helpful?
Sure. Yeah. Just I'm Brian Pitkin. I know a lot of you folks, and I just have the RFP that we put out for the child and family behavioral health specific trainings. We heard back from folks that they wanted trainings on collaborative problem solving, as well as the nurtured heart approach, which is pretty much like an engagement strategy that you can use in a clinical setting and just in an engagement outside of a clinical setting as well. And then some cultural humility pieces around diversity, equity, and inclusion. And we're looking at having the nurtured heart approach trainings start in the end of January. And so we'll be getting information out to you folks about that. And we're going to try to focus a lot of those trainings for the first round on folks in leadership and management roles, and as well opening it to others just so that we can get feedback to make sure that the trainings we're offering are on course for meeting the needs of those folks that are providing the services. And so additionally, I guess the last piece of information that I think is pretty great is that we're going to be also extending these offerings to like peer support specialists, family support specialists, especially that nurtured heart approach, just getting that engagement strategy out there to whomever would like to take it. So that's the information on that. More to come. Excited to see what impact the training will have on the services delivered, and really excited that we're able to do this training in direct response to the feedback we received from the families we serve. So thanks.
Brian, do you have any updates on the diversity, the 6-part series, and when those will be offered and when registration is going to open for those?
I don't. I know that they're talking beginning of February, but they're finalizing the flyer for that now. And so we'll have registration links for both the Nurtured Heart approach and the CPS and the diversity, equity, inclusion coming out.
Great, thank you. So the Nurtured Heart approach is approach that some of our the MRSS teams across the nation. There's a couple different states that have chosen to train all of the staff in the Nurtured Heart approach. It's new to Oregon or new to many of us. So again, just to reiterate what Brian said, is we're going to reach out and do an intro and have the supervisor, maybe managers, whoever you would think would be helpful. We just want a couple of you to come and do a couple pilots of an intro to it, make sure that it makes sense and that you guys are seeing the value of it before we open up. I think it's like a 6-hour, maybe 8-hour training. It's just a day-long training. You do not have to be a clinician. And then we will offer a series of those one-day trainings and some coaching in the Nurtured Heart model. And that would be open to any staff working in mobile crisis. And again, it's specifically an engagement strategy for youth and families. And so again, wanted to just reiterate that folks were asking for non-clinical level interventions. And so this was something that we wanted to be able to see how Oregon might align with this model and if it might be helpful for your staff. So the family support specialists, the peers, the QMHAs, and of course, clinicians as well. You just don't have to be a clinician to attend. You guys are more familiar with collaborative problem solving training. We will be offering the level 1 and then eventually the level 2. They stopped calling it tier 1 and tier 2 training because it got, I think, confusing with tier 1 and tier 2 and tier 3 in the school systems. It was confusing, and I think that might be why they changed it, because they do a lot of work in the schools. So sort of, I don't know what the new name is, but we used to call it tier 1. So we'll do the first training and the second training. The one thing that I wanted them to do, though, and that we also are going to add into that, is coaching. So both in the Nurtured Heart model and for collaborative problem solving, to have small groups of crisis workers that will be able to come back and get some ongoing coaching. So after tier 1, just learning how are we going to use this, or what's the value of it, and how do we sort of work through. So offering some coaching sessions between after the level 1, and some of those folks may choose to go to level 2, but level 2 will be probably a smaller group of people that might be interested in that advanced training, but we'll probably spread them out about a year. So those are the 2 coming. And then Brian, like you said, the diversity trainings are a series. It's a 6-part series. Can attend 1, you can attend 3, or you can attend all of them. But we did not make it mandatory for all of your, mandatory. None of these are mandatory for any of your staff, but they all would count towards some of those training requirements that are required for your mobile crisis teams. Questions about that? And this is outside of the training academy and is not meant to replace the training academy. All right, excellent. Well, let's jump into it. Since I wasn't here, really, I was in and out last time when we talked about stabilization services and sort of when to refer, when to enroll youth into this 8 weeks of extra services. I don't know. I just like maybe you guys could give me an update on what were some of the takeaways from that. What are some of the themes that you guys saw? Was it helpful? Was it not helpful? And what did you like, what were your takeaways? And I don't know that everybody who's here today was there last month, but that was a topic that you all chose to have and that was important enough. So I just love if anyone would volunteer, or a couple of you could volunteer to just give us a summary of sort of some of your aha moments or things you took away from that last discussion. Any brave souls on this Monday morning? Feel free to unmute. Thoughts? All right, I'll change it up. How are you guys deciding? How are you guys deciding who's being referred to stabilization services? Let's change it up and start from the beginning. How's your agency? Because that was the thing that people were struggling with. People were struggling with knowing when to refer or to enroll a youth in stabilization services. So how are your agencies making that determination? And I know you guys are just starting off, but even if it's just a theoretical sort of thinking about who you would. Go for it, Jeff.
Hey, Beth.
Hey.
So I know you and I got to talk one-on-one for a bit, and after some of the collaboratives that we've done, pretty much the biggest thing that we're looking at is not overthinking the whole stabilization thing. We do have a number of people where it's just a very light contact and there's not really anything need, but as far as considering somebody in stabilization, if it requires us connecting them to any of our internal clinical services, whether it's even if we're just trying to speed up the process of them getting connected to one of our child outpatient teams, and our clinician isn't going to necessarily be doing it, but one of the other programs is, we're just calling that stabilization. Even if we're not worried about the acuity level or anything like that, it's just easier if we're jumping in and providing any of these services, it's just easiest to just call it that and just go from there.
Yeah, and Jeff, can you also speak to what about the kids that you used to treat or used to enroll in CATS? Where are those kids going? Are they now all being enrolled into, are they still being enrolled into stabilization services? Because MRSS, the SS part was to replace the CATS program for those of you that used to do CATS. How are those referrals going? And are you still enrolling those youth in for this extra support?
Yeah, pretty much. If my team specifically, if any of my clinical providers or skills trainer or anything like that is getting involved, then we're calling it stabilization, because it is helping keep them from get to that next level or escalating or worsening or anything like that. And it just makes it easier to not overthink it. And we're already doing the work. We might as well be showing that work that's going on, because it's still telling a story of preventing recidivism and stuff like that. So
yeah. So part of the reason that we transitioned from the CATS model, which was you could only enroll kids into 45 days of services and supports if they had a high level, they were suicidal. The ED was saying we're not going to release them back home unless they have extra services in place while they're waiting for their next place. So it was a really high threshold for getting into CATS. And when MRSS was introduced, we were thinking about the whole model is about reducing the threshold and not having to be referred specifically from a hospital, although you guys probably will have referrals from the hospital and many of your teams are the hospital or you are the team that goes to the ED when somebody presents there. So part again is thinking about how do we capture those high level kids who really need services and supports and safety planning and all of that. If they do present to the ED, can we support them in the community while connecting them? But also what Jeff was saying is there is a shift, right? We're shifting away and thinking about how do we get into the home sooner? And how do we identify and use the 8 weeks? Can we use the 8 weeks to continue assessing the needs of the family and helping connect them to services? Because sometimes the services don't always have to be based in mental health, right? So you may go to a family, right? You may be called out for an emergency situation, and this family may be new on your radar, and they have stuff that's flaring up. And can we help connect them and do a deeper assessment and a deeper dive with the family to help connect them to services to keep them from being, if we fast forward, we're trying to also, this model is trying to keep kids from ending up in multi-system involved, to help these families access services now so things don't have to get worse. So it's this preventative sort of thinking about it. So thank you, Jeff. The other thing I just wanted to ask you guys is that what do you guys think about this whole idea of one of the core components of mobile MRSS is sort of this idea of shifting our thinking about what constitutes an emergency? MRSS was never supposed to. I was looking for a video for somebody. There's a video from our national SAMHSA or NASHMIT or one of them that talks about one of the biggest problems that some of the states are having in rolling out MRSS is that they're trying to shove the kids program into an adult program. And what I mean by that is, and in Oregon, we somewhat are guilty of that, right? We have mobile crisis for the lifespan, and then we're thinking about stabilization services as sort of this add-on. So it's like, we're going to keep doing our thing. And then if it's a youth, we're going to think about enrolling them in these other services. And I'm just curious how we might be able to shift that a little bit, or start shifting our thinking, at least, even if in rules, it looks like stabilization services is an end at the end of the rules. How do you guys start thinking and explaining about this model? The core tenet is, if a family is picking up the phone to call your county crisis line because they're at the end of their rope and they don't know what else to do, and they're asking a stranger for help, that should be enough for us to give a response. So we are shifting the definition of when we respond and shifting it and encouraging. Now, we haven't started the media. I told you guys that a while ago. We haven't started advertising for 988. We haven't talked to the parent groups yet and said, hey, we're changing our thinking. We're slowly sort of phasing this in. But what do people think? I saw someone's hand go up, and then I'd love for whoever it was who had their hand up to, how are you guys explaining this model to your employees, to each other, to the community? What words and how are you explaining? It's not just stabilization services. It's from the very first phone call is when this full MRSS model starts for youth and families. Amy?
Hi, this is Amy from Benton County. So I mean, ours is, it might be similar to how other people are doing it, but like our crisis team that are the ones that do the MR part of it, and then they just refer everybody who's 20 and under over to us, and then we make that phone call to just check in, see how things are going, follow up on the crisis, and see what services they're wanting, needing, and then we just kind of assess from that point. And so it is very, individualized, just depending on what services they already have in place, what they're wanting. So it's really different for every kiddo that we contact. We we've evolved, we've changed, our process, over time. But right now, like if it's somebody who has a guardian, then we will have our family support person call them to make that initial call, just to connect, and then say, okay, our care coordinator will reach out to you and talk more about services that are available, that might be available. Yeah, and I think, just to speak to what you're talking about with level of crisis, what how the family feels, and everything like that. I think we definitely take that into consideration. We don't really, if somebody was seen it by our crisis team, then that's, that's enough. That's enough. But as far as opening it up outside of our crisis team, we haven't really done that yet, because just for sheer capacity issues, being, because I don't know if other counties have experienced this, but like once word gets out that there's all these services that could be available if you just make this one phone call. I mean, that is just going to like open the floodgates, honestly. And like, we just don't have the capacity to do that at this point, to be able to offer, you know, uh, all services to all of those kiddos. So, right now it is mostly the kids that are either, coming in to see our crisis team through our counselor of the day, or kids that are seen at, a crisis at school, or a crisis like at the ED, had been seen in the ED.
Mhm.
So,
Have
yeah.
the families, when the family support specialist connects with them, have you seen that that's been helpful for the families? And are there cases where that family support specialist is the only service that they're going to get while they're waiting for a period of time? Has anyone, I see a couple of heads shaking. I'm just
Yeah.
curious, because part of the model, I know we think about what mental health services do you need? And if you have outpatient in place, you don't need stabilization services. And I want to just challenge that a little bit. And I'm not saying you said that, Amy. I'm just saying in general, I want us to think a little bit about early prevention and assessment. And are there things that this family could benefit from to help them today to keep them from continuing through sort of the system of care?
Yeah, so like for us, like if say a youth comes in, they already have outpatient therapist, but maybe they could benefit from some skills training to add it on to their, and that's not provided through their therapy office. Like we might offer that, or we might offer the family support is always something that we offer. We also have a youth partner, so we can offer
Right.
that. And so we do have some kiddos that all they're receiving right now is a youth, contact with a youth partner, because that's all they need or want.
Great.
Some of it might be just family support. Some of it might just be therapy. It just depends on what they're wanting, what they're needing, what they already have in place.
Yeah.
So
Perfect.
yeah.
And I mean, I think that that's some of the shift, which is if we assess a youth, if we go out for a crisis, we offer sort of this, hey, can we walk alongside you? And we'd like to stay connected with you for the next 2 months to make sure that things don't re-escalate. During that time, sometimes you find out more information or there's more needs. And so how do you then connect them? And again, not every case is going to be 8 months or 8 weeks. And even statewide, nationally, some of the programs are 4 weeks, some of them are 6 weeks, some of them are 8 weeks. I think the amount of time is sort of, it is, we have to pick something, right? But there's nothing magical about those timelines. Other thoughts about, can this FSS provide stabilization services prior to a QMHP assessment? Yeah, so we ask, typically there has to be a service plan in order for the FSS. For stabilization services, there's no way to pay for. That's how you are able to have you have to have an assessment. You have to have a QMHP assessment, and then you have to write a service plan. Obviously, a service plan for 8 weeks is going to look very, very, very different than a service plan for ongoing mental health therapy. So the service plan may just include care coordination and family support. But it's the service plan that unlocks, I hate to say it, but it unlocks and increases the ability to bill for those services. But I don't expect the QMHP assessment might be there's some bare minimums that have to happen for it to be considered an assessment in Oregon. And then the service plan too is very, it has to have goals, objectives, and interventions, but your interventions and your goals may be to assess and keep the family stabilized while waiting for service and longer term services. But yes, the FSS, if they're on the service plan, if then they're OHP, you guys should be able to bill for those and use the right code. You just have to use the right codes. If the FSS, I think everyone gathers information, but typically a QMHA rules, a QMHA can gather information. It's really, but that's a bizarre question. I mean, not bizarre, Tammy. I mean, it's a good question, which is, the FSS, of course, is going to be sharing information with the therapist that they're learning. But technically a QMHA is approved to sort of do that information gathering. but what's the difference between a QMHA and if a family support specialist learns valuable information, they of course are going to pass it off. So the hard one to, yeah. Tammy, go ahead.
Oops, I did find my mic.
You
did. If we're providing the services and letting families know that they don't have to get to the state where they're having an official crisis before they can receive the stabilization services, and the family support specialist goes out there and talks to them, and we have a lot of people that's who they feel comfortable with. They don't want to really enroll in services, but our family support specialists and our peers are amazing and through the hoops. But we always record those as connect visits because we don't have a QMH, which are non-billable. They're just our internal file notes. I should have used that term because there's not an assessment in place. So I'm wondering how we get around that if we want to, encourage more of this. You're going to have the fiscal people like me saying, what the heck? Why are we doing all these non-billable services when they are very valuable and they keep people from going to crisis, but we just don't have a mechanism in place to build them unless, my understanding, I'm totally not clinical, is that the Columbia screening, the suicide screen, reading the OARs, it looks like we can provide services doing a screen, and then we raise it to the level of the QMHP if the screen indicates that they're at risk. But sometimes they're not at risk.
Yeah, they actually don't. So my question would be if the QMHP is going out to a home is part of the 2-person team, they're already doing an assessment. So why not just use the assessment that they did when they were out at the home, use that mental health assessment. Some of you already are picking a diagnosis at the end. A mental health assessment is a bunch of screenings and then justification for services, which could be justification for enrollment and stabilization services. And we already are saying you don't have to have a mental health diagnosis to get stabilization services. So if there's a Z code or something else, why not just use whatever your 72-hour staff did? And then, yes, does there need to be a service plan? Yes, somebody needs to follow that case and make sure if a further assessment is needed. But I think a lot of you are using whatever assessment you do in the first 72 hours to then justify stabilization services. And if we're saying that you can have stabilization services based off a need, not diagnosis, then sometimes those assessments may end in a Z code, which may actually now be covered for some youth. So just again, remember EPSDT changed the rules. There is no more above the line. There is no more below the line for diagnoses for outpatient. It's based off of medical necessity. So I find it that most of you might be comfortable giving a youth a Z code or some sort of something after that. And then there's going to be situations that you don't. So I can't say everything is across the board, but that's how I'm looking at it. I don't expect you guys to do a 5-hour mental health complete biopsychosocial for a youth that you might serve for a week or two, but you do have to have enough information that you can then justify the need for stabilization services. Doug, super interested. You got that look on your face.
The look I always have. So I don't know about all the other counties as far as staffing, and don't get me wrong, I love the 2-team approach, QMHP peer. Obviously, we've done it like once or twice. We just don't ever have the staffing for it. So I agree with you, Beth. Like when we've gone out with like a QMHP, and let's say I go out with one of the peers, obviously I can do the assessment, and I usually gather enough information, and the peer does all the work. I just listen and jot down stuff. So I agree with that part. I'm wondering if what Tammy's talking about is all the times up until this point, and even in the near future, when, like for us at Polk, we don't have the staffing to go out to people all the time.
Right.
But our peers are front line. They'll take walk-ins right out the gate. They'll take phone calls. And I'm still under the impression we can do an assessment over the phone. But because they can't do an assessment like what Tammy's talking about, they have to do a connect because they're not open to anything. They're not open to crisis. Our peer can't do that, yet they're the front line. And a lot of times they don't need a P. They just take it, work with it. And from a client focused lens, I guess, it makes more sense for that peer to continue working with them. But here's our dilemma. They can't open, they can't bill, and then they have to call one of us to come in, which isn't really conducive to the client because now it could be a little overwhelming for them. So I would love for y'all to figure out a piece where, you know, even if you could bill whatever it is, that's for all you smart people that understand numbers.
Yeah.
I don't understand any of that.
Yeah.
But if there was a way that a peer could open something up, we would be keeping a lot of it's just more cost effective because you don't need the QMHP to roll in there to open everything now.
Yeah.
And
So basically, Doug, oh, sorry. So basically thinking through a scenario where, and given all of, I get it that there's staffing stuff. And of course we're working towards these 2-person teams and all of that. But what I hear you saying is there a scenario where if a peer goes out there and they connect with the family and the family would benefit from having ongoing peer support services in place, is there any way for them to continue to support that family without having to have a P get involved at all? In whether or not we call it stabilization services or just bill, is there a way for us to do that?
Right, because I mean, yeah, that is the exact question, and that would be a sweet holiday present for at least out here in Polk. We are smaller, as most people know. We are smaller, but one of the advantage to that is we have peers that have been here for 5, 6, 7 years, and this isn't just I'm going to give you one example. I'm going to give you something that's a multiple example. And that is the peer knows the family, knows the parent, went to AA with them, got them into services. But we're not talking about the mom or the father. We're talking about the kiddo. And so it naturally makes sense that the peer would go in there. Right. Even if at least for the first 72 hours. Yeah. Like what she's saying, like, if they could open it up for even that 24-hour period, and then the QMHP can come in, do an assessment. I mean, we wouldn't really need it in the 24 hours because we would just get them set up with our outpatient team, which I believe her name was, I wrote it down, Amy from Benton County, kind of that same mentality. But yeah, if we could have a mechanism to have them open up, that would be great.
So the rule, so again, yes, let's think about this. I don't know if I have all the answers, but you have my brain trying to go into its brainy part, and I am not the billing person either. One of the reasons we did create the rule to have a service plan was that was one of the only ways we could figure out how to have a peer keep working with the family so that we could get reimbursement. So that was one of the reasons. But the other reason for the QMHP assessment is that these are high needs families that we would, if they're calling and they've been in an emergency and they're in and out of the emergency room and they don't have mental health services in place, we do want somebody as part of this service to lay eyes on them. So we do want a QMHP to do an assessment, whether, to assess for stabilization services, just to make sure, does this child actually, do we need to get them on a list for CDRC because they might have some intellectual disabilities that nobody's picked up on? I know, so that's the value of the assessment. But that's not what I hear you questioning. I don't think you're questioning whether or not, that's a need. I think what you're saying is if a peer and a QMHA go out to a crisis response, or if it's just, I hear that you guys say that sometimes you're only sending one person. So if they go out, they can work with, if the two people go out, they can actually, the peer can work with that family for up to 72 hours under the, and get paid the enhanced rate if you guys meet the requirements for the first two. So they can continue to work as part of that 2-person team. So you can send a QMHP and a peer as your first responders. You know that already, and do the 72 hours. They also can recommend, they can also then at the end of that recommend stabilization services, and then you guys could send somebody after the 72 hours. Then you have 72 hours to get them enrolled. Does that make sense? Like, you could have that peer support specialist work. We also, just look in the billing guide, because I can't speak to the billing like I've told you guys, but we also put a little clause in there that says, keep using H2011 without the modifier, with whatever the modifiers are. I know it's a little confused. Keep billing until you have the service plan in place. And we're hoping that'll be a week, not too long. So we do know that like 72 hours to get a QMHP assessment. Maybe it's 80 hours, maybe it's not. We still want you guys to be able to bill for it, knowing it's in progress. So there is a little leeway in that, at least the way I read it. But if you feel like the rules don't support that, let's talk more, because again, we want this to be supportive. The other thing too is what we learn right now, we also, so in order for us to have those peers be able to be covered, we had to do a whole state plan amendment, which is way above me, and Medicaid people to be able to get the peers a new, like the peers to even be able to bill for be part of the 72 hours was a big deal. So I know that there's ways to do it. It just takes time. So if we need to change something in the next 2 years, we may have to go back to the drawing, look at some of that, Doug. Gabby?
This is unrelated and yet related to what Doug is talking about.
Yeah.
So we had a youth in Ontario, so it's close to Idaho. And so dad has custody. Mom did not. So there was an agreement there that somehow dad didn't have custody. Well, dad brought the youth over, and now the youth is staying with the mom who doesn't have custody. And so I've been working very hard in getting a power of attorney or even releases of information, and that has been challenging. So what I'm hearing is I could still bill what I'm doing under the H2011 based on connecting to services. So this is a youth that was identified for MRSS services, but I can't even do the assessment because I don't have any of the documents. So dad has completed the admission forms, but I still don't have the ability to meet with mom for that assessment, and dad is unable to come into Ontario due to work. And so that's kind of been the challenge for us, is really just beginning services.
Yeah, there's something in that billing guidance that says during the period where you're trying to do the mental health assessment and get them enrolled, that we want that to be as soon as possible, but we also understand life happens, that shouldn't be a penalty to you guys. So there's something in one of the numbers that says we realize CMS, those people way up there that, live in that place, they're the ones that are pushing for us not to use crisis codes. Like, crisis has to end at some point in time. So they're the ones that challenged the use in Oregon, around, not just Oregon, just nationally, around how come we're using crisis codes for 10 months? Like, crisis has to end at some point in time. Now so that's where that 72 hours for those crisis codes and that came, but we did put a little bit of a flex in there. I just don't know. I don't have the guidance in front of me. I don't know what number it is. Heather, I don't know if you're looking at the guidance and that you can put the number that the question is in the chat box for me. But all of that stuff is addressed, right? We want you guys to be able to bill for everything that you're doing because you're doing a lot of hard work, and understand that we still have some, like you said, Doug, like everything you said totally makes sense to me. And so how do we think about it and see if we need to sort of course correct at some point? It just takes time, right? Yeah. Tammy, and then Miriam, I see your hand. You're muted though, so I think you might be talking.
I was talking. I think that in our minds, at least what I was meaning to ask in the first question is that with the stabilization services, and that's why I kind of went to the crisis world, or the first 72 hours, is they don't have to have an assessment. And the OARs talk about a screening,
Yeah,
and then a QMHP. But
yep.
Our world, if they're at risk, but in our world, for the initial crisis visit, or when a person first calls and says, I need help,
Yes.
if it's a pure QMHA that goes to them, we have it set in our world that they can't bill for the services they're providing because there's not an assessment and treatment plan. But I'm reading the OARs that that's not quite right, that we can do a screening.
Yeah, so again, I'd go back to the billing guidance. We are actually currently right now, just to reiterate, again, I'm not a Medicaid person, so I'm just repeating what's in that guide. You can send one person right now and use the one person modifiers right now until we give you at some point, we're going to say one person probably can't go out anymore, right? Like that's what we're moving towards.
Right.
The enhancement is 2 staff. We increased who those 2 staff can be. We wrote it into rules. Those 2 staff can be a combination of many different roles. Those people, there's a code now. You bill every 15 minutes. If it's the 2 qualifying ones, it's a much higher rate. Every 15 minutes you're billing for the time out there. You don't bill individually. The 2 people do not bill individually. It is one bill for those 2 people. That's why the rate went from $40 every 15 minutes to $105. They went to 105 to cover those 2 people. So you're not having both people bill. You're just billing for 15 minutes increments. And if it's the right combination, it's the higher rate. And if it's not, it's the lower rate. And Luke has all of those in that billing guidance.
Right. I totally get that. I think
okay.
Our thing is from more of a clinical point that we are of the impression that we cannot bill for any services until the person has a assessment and treatment plan. That's why we've always written off.
So that's not true. Crisis services are different. So crisis services are the only services that you can provide in our community without having a service plan because it's crisis oriented. That is part of the reason the crisis has to end at some point in time, which is why it flips to outpatient codes for the stabilization services. So crisis services, but you are correct. In outpatient, that is the rules. In outpatient, you have to have a mental health assessment, a service plan, and then you start services. This is crisis work. The rules and access to the codes are very different. Is that everybody is understanding? The people, yes. So everybody's shaking their head.
Thank you very much. I love
that. Yes. It is true for all the other services, but not in crisis, because a lot of times you guys are out there for an hour and the person you're walking side by side around, with the person. You're not diagnosing. There's no service plan.
Right.
And another thing that you brought up, and again, if you guys want to talk about these in depth, put it in one of those Microsoft Office forms and send it to us for office hours. But again, a mental health assessment by a QMHP may or may not be needed in that first 72 hours, which is why you can send a peer and a QMHA. Is not every person, but they have to have access. If Doug and I go out and we're not QMHPs, I'd better be able to call a QMHP and have them do either video, telehealth, or come to the site if that person screens positive for high risk, if they're suicidal, if I need a QMHP, if they're looking like they're going to need to go to the hospital, I need to call a friend. But if Doug and I are both QMHPs, we there are on site and we can do everything we need to do. And sometimes that it may or may not include a mental health assessment. So
That is so awesome.
Yeah.
Thank you.
Yeah, totally. Okay, I got Doug asking and then Miriam. Go to Miriam.
Go to Miriam first.
I was curious how counties are dealing with private insurance, youth with private insurance. Maybe that's a can of worms. I see your face, Beth. And we have not implemented MRSS yet, but obviously we do crisis services for anybody. You know, we don't stop and ask them what their insurance is before we go. But really for that stabilization, I'm just really curious how counties are handling that, or if they're not handling it yet, like why or what your plans are. So, because I know we're supposed to see everybody regardless of insurance, but it doesn't mean they get free care regardless of insurance, right?
Right.
So,
I mean, the service 25A, you know my answer. This is, and you're not asking me, Miriam, but I'll tell you my answer, and then your peers can answer. But we did want to make stabilization services available to everyone in the community. So we did add a new service element 25A, which does give you some funding. However, we don't have a great idea of how many youth and families are going to access the service and what those totals and numbers need to be. So that pot of money there is available. But your question is to your folks, what are you guys doing with the private insurance?
Knowing that we have that service element funding, but like are counties asking those families to fill out like fee agreement form? Are we gathering income information? Are we just saying it's free for everybody, even the super wealthy? You know, I have a lot of questions about that.
Yeah. Washington State was able to push through their legislation and get private insurance to cover crisis services last year. Oregon, obviously, we've been watching them closely, but also I see Tammy, can the state push? The state's pushing, but also I encourage you guys all to also push as hard as you can in your all of your circles as well. We did get the 40-cent tax, the telecom tax this year. So there will be a new trust that starts in January where everybody's cell phone is going to put 40 cents towards, I don't know exactly how it works. That money though starts with the call centers and trickles down. So I don't know how much will actually come to our front doors for your guys's, but that's one thing to think about. Amy, I think Amy's up and then Lauren jumped in because she's our legislative guru.
Hi. So I'm not the billing department, and
Yes.
I know it's
Me neither.
it's like everything else. It's went through some evolutions, but I think maybe what we're doing now with private insurance is that we bill insurance, but if there's a anything that isn't covered by insurance, then we write off. So we actually don't send a bill for the period of time that they're in stabilization services. If they're rolled into our outpatient program, then that's just billed like it normally would through outpatient services. I think that's how we're doing it now for private insurance, but I'm not 100% sure on that.
Thanks, Amy. I think that there's pretty strict rules around what you can do as far as follow up with the OHP clients. You guys are all well aware. We usually don't go after the OHP families, but as far as private insurance goes, you guys are also encouraged to start conversations with your local, if you haven't already, to see what they're willing to pay for and if there is any agreements that you can come up with. Some of you do have contracts with some of the private insurance. I don't know how it works or how you are able to do it, but I know it's not impossible, but it's definitely not easy. Lauren, I see you put something in the chat box too.
Yeah, I just wanted to provide a little clarity on the tax, and I'll be super quick. And then just a side note, I know that some counties have had some success with MODA insurance. If you're not already looking into MODA, that might be the one avenue for you with private insurance, but I know that's limited. One really quick clarifying on the 988 tax. I just don't want anyone to be getting their hopes up. The reality is that 988 is really expensive, and the tax is going to largely go to 988. And the long term, we have it until 2030 as of right now. Telecom users and coming on board is not going to go up as quickly as 988 funds or operational costs will. So if the CMHPs do receive anything for mobile crisis that is left over, the biggest amount you will ever see will be in the first year. And then that will slowly trickle down because telecom users are not rising as much as operational costs. So I just want to give a point of clarity because I think some folks have been holding out a lot of hope that there will be a cash infusion, and that is just not the reality of how that's going to work. We are working on some documentation to kind of be able to explain that so that you have something to share with your teams if folks are getting a little bit confused. But I just want to put that out there so that folks aren't thinking they're going to get a whole bunch of money, at least through that.
Well, thanks, Lauren. No, I'm glad you're honest, and it's a big system, and there's lots of moving parts to it. So we'll see how that plays out. But I do think it's important for us to know that, there's a lot of the money has to trickle all the way down, and there may not trickle very far. So I appreciate your transparency around that. I do think that we do have something to look into, which is the just the stabilization services, just about peers. I mean, if you're not, you should at this point, if you're sending 2 people out on your team, you should be able to be billing, not at the enhanced rate because there's yet, but you should be able to be billing for any of your crisis services in the first 72 hours. We have modifiers, we have different requirements. You should not be doing services for free. Now, with being said, we have ways to bill for OHP, and the service element is what offsets the cost for the rest. And we do, Miriam, which is what prompted your question, which is we're going to go out, but how do we sort of navigate this? Part of what we want you guys to do is keep collecting your data. I know it's a pain in the butt, and I know it's not everyone's favorite stuff, but the only way that the state can see how many private insurance youth, and so when you guys say, what can the state do to push on all of this? Well, they want data and they want us to be able to show them the numbers. And so that's why it's so important for us and for you guys, if you can, to collect what you can so we have a real picture. And we do appreciate all the data that you guys are collecting, and it really has been helpful to start looking at. We're not quite to the point where we're really comfortable using it for those purposes yet, because we're all still practicing collecting it and kind of figuring out all the glitches, but soon we will. So I do appreciate all of that. I'm going to send you guys a link to a video, after that I just rewatched, and it was, I don't know, some of you, and we've had Rick Dr. Shepler from Ohio, who does IABHT and MRSS and helped start him in Ohio. We've had him come speak before to our IABHT folks, but he also has MRSS in Ohio, and he's just pretty brilliant and really down to earth. And he has a video, he was a keynote for Texas who's rolling out MRSS. But I'll send you the link for the video if you have time. You don't have to listen to the whole hour, but I mean, the first even 30 minutes are really helpful if you need to sort of wrap your head around, why is this different? Why does it start when MRSS starts when a family picks up the phone and calls. And although we in Oregon sort of have separated MR and SS, the response starts from the phone call. The change in our expectations around what a crisis is, going into a home where there may not be, it may be bubbling, but it's not super hot, right? And trying to get in, assess, work with the family, and foul them if we need to keep them from calling you guys over and over and over again. We really want to try to keep these kids out of the emergency room and the long-term impact. And I think he just does a really nice job saying what we've talked about. And sometimes it's just nice to hear it from somebody else's, not me, right? Somebody else's explaining it. The other thing that I sent out that you guys might want to look at is there is SAMHSA. I always forget if it's SAMHSA or NASHMD, but actually it's the University of Connecticut who's the overseeing the MRSS rollout for the nationally. They also put out a guide for leadership. How do we talk about MRSS and envision MRSS and what would that look like? So I'll resend that to you guys if you haven't gotten it. It's been in a couple different attachments, but I'll have Maya send that out on later today. The link to the video and a link again to that leadership document where we're really trying to get to move the needle from crisis. It is always crisis response, but we want to be able to respond quicker to families because it escalates. And if you can de-escalate a child and a parent, maybe you can de-escalate that, but you can help. It's really prevention for the adults too. So if, it's not just it's the whole system approach. The other thing I'll say is that if you guys have services that are appropriate and you have openings in these services and a child you run into needs that service, plop them into the service, get them the services. Ideally, we would have access and no waiting lists for everything. But I also don't want you to think about MRSS as just a place while they're waiting for outpatient, because that's not the point of it either. So we'll keep talking about these. I'll see you guys in January. Happy holidays to everybody, and thank you so much for doing this work. It really is important, and we really are sort of trying to change our front door for youth and families and try to intervene earlier rather than later, which is beneficial for not only the youth and their families, but for you guys as well. Going to a home earlier than in the middle of the crisis might also help you a little bit as well with you guys are used to seeing such intense situations. So anyways, thank you all. More to come after the holidays. Take care. Bye.